position for the toe, or for the ankle, is the second toe. That's what the movable arm is going to go towards. All right, so this is all the tests. Speeds test, left shoulder.
All right, so speeds test is long head of the biceps. Okay, so if you think about the anatomy, your bicep does two things. It helps bend your elbow, and it helps you to rotate your hand into supination. Okay, so that's why if you're doing, at the gym, you're doing bicep curls, that's for your long head of your bicep. Hammer curls would do something different, and then curls with, palm down is different. So that's an important part of doing this test, because if you do the speeds test with the hand down, it's wrong. You want the hand definitely to be up, arm straight, and you're just going to resist as they raise forward. So keep straight, raise forward, and then you resist them there. And if they can not do it, that's an indication that they likely have a biceps tendon, long head of the biceps injury. They still may be able to do it, but weak, because their anterior deltoid is going to be able to assist them. Right, so as she does that, if you give her resistance and she says, I have pain right in through the biceps tendon, that's a pretty good indicator that it's injured. So it's not necessarily weakness because of the anterior deltoid.
So it's test positive if there's pain.
Yeah, when they say positive or negative, positive doesn't mean it's a good thing. It means it's positive for testing what you're trying to test, which is injury to the biceps tendon.
Good. Again, that's extended and supinated.
Yep, definitely, and that's an important step. Hand has to be palm up. That way is not testing it, so it would absolutely be.
Do it right here, right?
It would depend. You could resist here. I mean, if they couldn't tolerate that, I'd probably try here. But because you have a longer lever arm, you can push easier here to really aggravate that, because it makes it work harder.
Good.
I would push at the wrist for the testing purposes.
You don't have to push too hard.
Yeah, and it's easy. Like if it's bothersome, don't kill them. Just nice and easy.
Yeah, they might hit you. Hawkins Kennedy test, shoulder.
So Hawkins Kennedy's test for shoulder impingement. So if you think about the supraspinatus tendon as it goes under the acromion, it gets pinched under there. So you're trying to definitely recreate that irritation. They probably won't like you to do this one either, but what you do, you bring the arm up to 90 degrees across their body, and then you're going to rotate. And as you rotate that, it causes the glenohumeral joint, the humeral head, to press into the supraspinatus under the arch. So that's irritating. They're already having that pain, so you're basically trying to recreate the pain. And they'll say it hurts, and they'll say, yeah, that's it, it recreates the pain. And they'll probably stop you if you get it positive, because they'll stop and do this because they don't like the sensation.
Is it better to go like past 90 right here?
I would come across the body, yeah. So like have them relax and you just come across the body and tilt down. If they don't get it, you can bring it a little higher. The higher up you go, the more likely is that you're going to get the impingement. But like, I wouldn't bring it way up here.
Yeah. Okay.
So as long as it's 90 degrees flexion anywhere along the lines.
Yeah. But you want to bring it across the body because you really want to try to increase the pinching of the.
So again, elbow flexed, horizontal abduction, internal rotation. If you weren't writing it down for yourself.
Like they're not doing it on their own. You're taking the arm and torquing it.
And it tests positive if there's pain.
They'll have pain and a pinching right like at the rotator cuff, so right in the front of their shoulder.
So it's positive if it pinches, because you're looking for an impingement. So Lachman.
So Lachman, yeah, it doesn't matter. So you're basically checking the anterior cruciate ligament. So you want the knee to be just slightly bent. You can put something under that. Like if it works best, you can put a towel roll. If you don't have anything, just put your leg there and bend their knee over your knee. But then you're trying to stabilize the femur and pull the tibia forward. Okay? I'm just out of the way so you can see what I'm doing. But if you stabilize here, and you're basically going to try to rock it, And as you do that, if they tore their ACL, this part will slide forward. Okay. A positive test for that is laxity, is looseness, compared to the other leg. So you would check this, like even if she didn't injure it, to see what normal is, and then you would check this one and it would be looser. They may or may not, it depends. If it's a partial tear, it may slide forward and be loose, but it'll stop. If it's a complete tear, like it will feel like it just keeps coming. And so that's called a Lachman's test, and it's for your ACL. And
how is that different from the anterior drawer test?
So you're pulling the tibia forward.
I figured it's just less degrees of function.
What's that?
What's the difference between that and the anterior drawer test?
So the anterior drawer you have it bent all the way up here. Okay. It's doing the same thing. You're still trying to pull the tibia forward, but some studies have shown that because of the flexion of the knee here and the resistance of the quadricep, that the anterior drawer isn't as accurate. So that's why Lachman is. This is, you'll see them on the sidelines like of an NFL game. They universally just do that just because it's easy to do. Pain is not a positive test. It doesn't mean that they tore their ACL. The looseness or the laxity is the positive. Because if they tore their ACL completely, it may not hurt because it's a complete tear. The nerve fibers aren't intact, so they're not getting pain. If they tore their ACL, they should be able to get up and walk off the field. The ACL stops the tibia from coming forward, but it also stops your foot from rotating. So as long as they get up and walk a straight line motion without rotation, they should be able to walk off the field. So them being able to walk doesn't mean that they didn't tear it either. So the looseness is the positive test.
From what I found, it said like 20 to 30 degrees of extension, so there's barely any extension, but I don't think he gave us that. So as long as for the Lachman,
I don't think there's an exact number of like knee bend with it. As long as it's a slight bend.
I think he'd be fine with that.
All right, so anterior drawer for the ankle.
All right, so sit out here. So anterior drawer, I mean, it's literally just like the idea is that you're trying to slide a drawer forward. So it's testing for the anterior talofibular ligament. So you stabilize the leg here, and you hold the kind of the heel, and you're trying to pull it forward. So this is stabilizing, and you grab the talus and slide forward, like you're basically stabilizing, pull forward. If the anterior talofibular ligament is torn, it'll be looser, it'll slide forward, so you'll have looseness, and they might have pain in the front of the ankle leg where it's torn. Pain's not necessarily indicated that it's a positive test. Again, the looseness is the laxity is indicating that it's injured.
Can you do that again?
Can you do it with the other foot? So I can.
Yeah. So this one's hard to visualize because she's not injured, so you can't see motion. But you stabilize the tibia, you cup the heel, and then you just slide forward.
Oh, okay.
So it's this motion.
Yeah.
So I don't have a lot of movement, but if it would be like a real excessive movement.
Yeah, like you would see it slide forward more.
And that's another one you'd want to do.
You want to do both sides. You want to check the other side.
So just in case y'all missed that, it's sometimes with the laxity, if you're questioning if there's too much movement, do it with the other side, the non-injured side. And again, with both of those, it's like opening a drawer. So it's going to be a horizontal motion coming out, not so much a twisting or a moving up and down.
Basically stabilizing and pulling forward.
And it will actually slide out like a drawer.
Because if they just rolled their ankle or sprained their ankle, they may have pain at those ligaments anyway, but it doesn't mean that there's a high degree of damage, that the ligaments themselves are damaged. And that's what you're checking to see if the ligaments are damaged enough that it's allowing it to be loose and pull apart.
So with the knee, it had to be knee flexion 90 degrees?
No, just slight knee flexion for the Lachmans. The Lachmans is just slight knee flexion.
For the anterior drawer.
For the anterior drawer, it's the knee's bent to at least 90 degrees.
Like
I don't think he's checking
just the one direction.
Yeah,
Well, I'm saying-
but that's just for you to know, yeah.
It says ankle, so I'm saying, what angle is the ankle?
Well, so yeah, you put the ankle at 90 degrees. Yep.
Again, so the positive test is if the drawer opens, and that's the talofibular ligament. That's what you're testing.
Yeah, the anterior talofibular. And then the sub
Anterior, sorry.
Talar Tilt is
Taylor tilt.
Taylor.
Tyler.
Yatame tilt.
Taylor tilt. It's
So
individual.
this is a hard one to see too, but you basically are cupping under the heel and you're tilting it inward. So it's stabilizing the tibia, grab the foot, and you're going to tilt inward. And what you're checking for there is the calcaneofibular ligament. All right, so the first one checks the anterior talofibular, which is in the front, which is the anterior drawer. And then the Talar Tilt does the calcaneofibular, which is the second one, which is under. And so you're tilting from there because you want to see if that's injured. It will probably hurt them if they just sprain their ankle, so pain's not necessarily that it's a positive test. The laxity, again, is that it's positive because compared to the other side, it will tilt much farther. All right, you're probably only going to get one test of this because they just rolled their ankle. And so you doing exactly the same thing they just did, they're not going to really like you to do that. That is if you're seeing like immediately after they did it.
Is there much give on that? If you
So
see,
it's basically, if you have, showing you reverse, the anterior drawer you're trying to slide forward. So you're sliding forward. With Talar Tilt, you're going from here and trying to tilt, not the foot, you're tilting here because you're trying to stress the ligament which goes from here. So you're trying to cut there and tilt that apart.
That's from a neutral position.
Yeah, so from sitting, that seated position, you're just going to tilt stabilize, try to tilt this under, because you want to try to spread that.
So again, this is a calcaneofibular, and so the fibula is only on the lateral side of your foot, so you have to invert it, right? So if you're going to do the Talar Tilt test, there's no everting, because the fibula is not on the inside.
And that's one that you want to make sure, like I said, you're not doing the forefoot, you're not tilting the foot here, you're cupping the heel and trying to tilt the back part of the ankle.
All right, McMurray's.
Called the Talar Tilt.
Yeah, Talar Tilt.
Talar Tilt.
All right, so we're on are we good? Number 20 is McMurray's test of the knee.
Lay on your back. So either way, I can do either. So this is for the meniscus of the knee. All right, so the first thing that you would do is basically just see how they can bring their knee up and work on knee flexion. All right, because what you're doing when you do this is trying to pinch the meniscus. Okay, and then you're basically going to try to stress it, because when you put resistance here and you tilt the ankle, this side will open up, but you'll pinch the meniscus on this side. So that's what you're trying to recreate, is that pinching of the meniscus. And in doing that, I'm rotating your foot here, just internal and external rotation, just to be inclusive of the entire meniscus. So you're bringing tension, putting pressure here to rotate in, and then just rotating your knee back and forth and letting it come down.
Are you rotating her foot too when you're doing that?
Well, I'm rotating her foot, trying to rotate all of this.
The bones
and
on the meniscus.
I'm putting pressure here and here. So I'm compressing the knee and then pushing inward as you straighten the leg down. Okay, and then a positive test would be that she feels pain, or she may feel a clicking or popping or catching sensation. Sometimes you can feel it with your hand too on the knee joint, like if it hits the right spot.
As you're pushing in, are you inverting your foot?
Yeah, like I'm rotating it back and forth as I do it. And
Mr. McMurray's is what you're doing? Okay.
and then so you basically will bring it down into extension. If you're really not sure, you can let it come all the way and let it kind of snap, because that'll check part of the meniscus as well. Okay, so when you bring it up here into flexion, that gets the back of the meniscus. When you bring it in here, you're getting the outside of the meniscus. Okay, when you bring it all the way down, you get the front of the meniscus, and then you could do the same thing the other direction to get the outside portion or the inside portion of the meniscus.
That's still considered a test?
Mm-hmm.
So you would do both sides. And so it's basically you're trying to grind the meniscus and put pressure on it. That one's a tougher one to do. That takes a little bit of practice, so that might be one we want to practice when we finish here to go through.
Again, what are the signs of a positive McMurray test?
So positive would be that they either have pain, or they'll have clicking, catching, popping, or they may feel like something just got locked. Usually if somebody just tore their meniscus, they have a lot of swelling. The meniscus tends to make the knee swell a lot. And it's really common that they say, I don't know what I did. I played tennis yesterday and I got up this morning and my knee was really swollen. Like that's normally a giveaway that there's, because if they tear their ACL, they're gonna hear a pop and they're gonna feel like their knee gave out. Meniscus you can tear and you're like, you know what, I just tweaked my knee, but they'll usually keep playing. Then they get up in the morning and their knee's really swollen. So that's pretty good. Kind of directs you where to be looking.
And you're not really, there's not really a point of where you're inverting and everting. You just
Kind of
like
the
throughout the
process.
whole
Throughout the whole
rotation,
process.
just in and out throughout the
That's
whole
why I say
rotation.
this one takes a little bit of practice.
Okay.
There's a lot kind of to go on, but I'm just kind of tilting back and forth.
In and out, okay.
And then tilting. And then pressure coming back to this way. That was my finger, that part.
This is my hip.
And you may feel it if it feels poppy.
Yeah, I heard, yeah, you'll be able to feel like a little.
Because the idea is that if the meniscus is like, you know, the foam disc in there and then there's a big flap on there.
Right.
If that flop gets caught in the middle, they'll say, yes, something felt like it caught.
Where'd you hold? You were like holding on.
I'm just kind of pushing here and cupping your
okay.
knee. And then so
All right,
when I bring
so
it
I'm
out,
like-
I can put pressure
Yeah,
here.
okay.
And if I come back this way, I can bring pressure here,
Got it.
like back towards me, so then I can pinch one side or the other side depending on going inward or outward.
So in class we watched a video of one where she was prone and he was kind of pushing into it that way. Is that to kind of?
That's also for meniscus. That's
Just in
called
case of the hip
an
thing?
athlete's compression. So you can roll over. I'll show that. We'll switch knees. We'll do this. It's the same idea with that. Is you're just trying to compress the meniscus. So you would put pressure here and push down into the knee, and then you're going to rotate. Okay, and then the same thing. You would do it at different positions of flexion.
And so one thing about this, if the patient had a hip pathology or a hip issue, that kind of takes the hip out of the equation because he was moving a lot of the hip in that sense.
We're not getting tested on this one, but this is another one to confirm. An interesting thing about this one is if she had a meniscus problem and you put compression down through the knee at different angles and she's like, oh, that feels like it hurts. If you then do the reverse of that, it'll relax it. And so that's another kind of secondary test because, yeah, I think you hurt your meniscus because it's catching. Does it relax when I do this and distract it? And usually, yeah, it does. So that's another indicator.
Yeah.
If they already had a tear, wouldn't that kind of make it worse?
Yeah, these are more tests to confirm that they do or don't have a tear. Like in the state of Florida, you can go to therapy without having to see a doctor. So you can go for 21 days before you have to see a doctor. So it may just be that you're seeing them to, the physical therapist will go through this on the evaluation day to confirm what they have. You guys, I can't see a situation where as a PTA we would go back through these tests. I think it's the idea that if you see the therapist did the note and put McMurray's on the test, you know what they were testing for. I can't think of a situation where as a PTA, having been seen, you would go back through these. Because like you said, if they're already injured or had surgery and you're rehabbing them, going back through the test is going to re-aggravate it. So I think it's for you to be familiar, so if you see the names written down on the initial evaluation.
And a torn meniscus is a surgery incident, right?
Usually, not always. I mean, sometimes they'll just see how you do without surgery for 6 weeks.
Yeah, that's what they did for me, because when I tore mine, they were just like, we're going to wait, see what happens, and it ended up healing by itself.
Good.
So most people, if you took an MRI, probably have a meniscus tear. It just doesn't give problems. And so they'll usually wait, particularly if it's somebody that's younger. If it was like me, they'd say, okay, you don't have good blood flow to your knee, you need to have surgery. If it's a 20-year-old or 18-year-old, let's wait and see if it heals on its own.
Okay. Thompson's test, Achilles.
All right, Mark, so what's the way, how do we remember Thompson instead of Thomas?
Oh, it was the,
right?
Brad Pitt?
Brad Pitt?
Brad Pitt, that's
so
it.
Brad Pitt has a P, last name's a P. He played Achilles. Okay, so Thompson is your Achilles. For 20 years, I've mixed these two up, and he told me that the other day, and that just made sense. It was just obtuse enough that I could remember it. But
it's true.
Thompson, so if their Achilles is intact and you pinch the gastroc muscle, because it's intact, it'll cause her to point her toe. So that means that it's fine, it's not injured. If you do that and this doesn't move, that's a positive test that she has an Achilles rupture. Usually a pretty good indicator that if they tear their Achilles, they feel like they got kicked or that somebody hit them with a ball or they got shot, because they'll hear it snap. And so it's really common that they look back to see who kicked them. And they'll say, I'm not sure what happened, man. I just did this. And so you just pinch.
And so you want the knee straight?
Yeah, you want the knee straight. Yep.
And the foot should go into plantar.
Yeah, it should plantar flex just slightly, like not a lot, but see how her toes point down? So that's indicating that it's intact.
And is there any visual thing that you can look at the Achilles?
If there's a rupture, Achilles usually ruptures right where the Achilles tendon meets the muscle belly, what they call the musculotendinous junction. They may have a big divot right there if you wanted to palpate, and it'll be sore.
Or a pit.
Yeah,
but right. Sorry.
But it usually happens too. They'll say, "Wow, that hurts right there," and you can feel it. It'll feel like, I don't know how to explain what it feels like, but
this is noticeable.
Yeah, you'll feel it. I mean, it'll have a divot.
And that's the uncomfortable picture in the book where it's just like.
Right.
I don't like that picture. So empty can test.
Up and down, up and down.
Oh, and again, that test is positive if the foot doesn't move.
If it doesn't move, right. If it moves, that means the Achilles tendon is intact. That's what you want. So empty can, so you want to bring forward into the scaption. All right, so slightly forward, rotate down like if you're pouring out a can. So this is a test for supraspinatus, which is a rotator cuff tear. So first you want to see, our muscle test, if they can raise against gravity, that's at least a 3, all right? And then you could apply light tension, so keep it down there, and then you just apply light tension. If they have a tear, they shouldn't be able to hold it up there, it'll drop. So it's just, it's really just really light tension. And usually what will happen, either they can't even raise it against gravity, they'll hike their shoulder to kind of cheat and do this, or if they can fight and get it up there, once you tap it, can't hold it there. And that's a pretty good indicator that they have a rotator cuff tear. It may or may not be painful. If it's a complete tear, they'll usually have some degree of pain because you're also putting it into that impingement position again, and the impingement will poke right into where the tear is. So this position itself is oftentimes uncomfortable. But a true positive test is that what they call a drop arm test. Her arm will fall.
And if they can't do that at all and it just falls, that's a
pretty good indicator, and that's when you would say it's less than a 3. It's probably a 2, because they can't hold it against gravity.
And specifically, this is testing the rotator cuff. Anything more specific than that, or
The supraspinatus, specifically the supraspinatus tendon, because the supraspinatus 98% of the time is the one that tears up the 4 tendons. Very infrequently subscapularis will tear, but it's usually always the supraspinatus because it gets pinched under the acromion process, and over time that's what causes it to tear.
Is there going to be a difference between this test and the Hawkins-Kennedy?
The Hawkins-Kennedy is more for the impingement.
Okay.
And so the Hawkins-Kennedy is coming across and it's just trying to irritate the tendon, which is already getting pinched. So you're just checking for impingement. This is specifically to see if the supraspinatus is intact and it can hold the weight of the arm.
Is this a tear?
This is for like a supraspinatus tear.
This is for the muscle, right?
Yep.
Because the other one was for the ligament, supraspinatus ligament.
Well, it's still for the same muscle, but it's just different degrees. One is to see if it's getting pinched under the acromion, and this is to see if it's torn. So if we have our skeleton, so the supraspinatus, right? So it starts back here, and it goes under this, it goes under that hole there and attaches to the glenohumeral, the humeral head. So what you're trying to do to see if it's pinched is you're bringing this up, you're pinching it under the arm. That's why when you rotate it, you're pinching it. So you're trying to see if it just has irritation from being pinched. If that pinching continues, it'll get torn right there, and now they won't be able to hold it. So now the two oftentimes go together, but you're trying to see is it the difference between impingement with the Hawkins-Kennedy or is it torn with the empty can test? Okay, and now that's why I said once you rotate this, even for the empty can, it pinches right where that muscle generally gets pinched. So it may hurt. So pain's not necessarily a positive sign for the empty can. The empty can is that they can't hold it there.
Everybody get on that? Hawkins-Kennedy, an empty can test.
The
What's that?
Hawkins-Kennedy is kind of like this, and you're rotating.
Yeah, I would do the Hawkins-Kennedy first because that's checking to see impingement, and then I would progress to see, you know, if the pain was from impingement or if it's torn.
If it was torn, would you be able to even do the Hawkins-Kennedy?
Well, yeah, because she's not lifting it. Like I'm taking it on I'm the one taking it this way, so I'm passively doing it. Sorry about the boob bump.
It's fine. Happens all the time.
Okay, so a positive test for empty can is if she drops her arm.
Drop arm, yes. They'll call that a drop arm test instead of, sometimes you'll hear drop arm test because they did that and when you tap it like it drops.
And a positive test for Hawkins-Kennedy is if there's pinching underneath the acromion.
Yep.
Good. So a Thomas test for hip flexor.
So, sit out here on the end.
Well, not move that.
Oh,
Psych.
sorry.
Alright, so scoot out towards me a little bit so you're way up towards me. And then pull this knee towards your chest. So you can pull back, hold that down, hold it. No, like right hand around the knee. Now lay back. Sorry. And then a positive test would be, this is for hip flexor tightness. A positive test would be that she can't keep this straight. Alright, if she lays back, this will come up, and that's a positive test. If you're not quite sure, what you can do is push down here for the rectus femoris, and she should be able to do that pretty easily to hold it in place. If
Closer to the edge. No.
yeah, you would screw her down as she lays back instinctively. Her body's going to kind of slide. That's why to do it, you start them way out on the edge.
Does everybody get what the positive test is? Because I'm positive.
I know
for
you're
it.
positive. Like
Yeah,
you show it.
I can do it. I'm pretty positive too.
Yeah, I'm
I thought you
Go
started with
ahead.
them down though.
What's that?
I thought you started with them already laid down and then you pulled it up. Everything.
Yeah, you start them sitting up. You sit them up and then you help them.
So in class, we were told to sit on the edge of the table. Just so y'all remember that.
Well, those pants are gonna give you that.
But my
information.
But you'll get the idea. So then you like, so see, this is a positive. Wow. If he's farther back on the table, you can see there's a larger indication because you'll see the gap here. So that's a positive indicator. And then if you try to push down here, you'll see his pelvis rock forward. That's just a little extra bonus. Or if I push down here, when I let go, this will spring back. Okay, but the positive is when he does it, there's a gap here.
That's just
Wow.
That's what we
Yeah,
do.
so then a stretch from him would be to give him exactly this test. You could hold here, you could hold it here, lock in place, stretch him out, and he should feel it in this hip. Because the one you're testing is a straight leg.
How big does the gap have to be?
Just as long as it's not flat. Just Flat means that they're flexible. If it comes up off the table any amount, it means there's tightness.
And that's
So
going to
then
be meaning the rectus femoris.
I mean, it would be varying degrees of tightness. You might say moderate tightness, maximum tightness, whatever, but it still would be the tightness on.
Negative.
guess I have
But
a
they're
slight
lumbar
positive.
too, because if they get excessive lordosis
Well,
when they're doing that,
it's
it'll come
still
back.
And
a decline.
that's a good point.
There's no
When I said
incline.
His pelvis would come up. You'll see him arc his back. So if I push it down, his back will arc because it's got to adapt somewhere.
And that was very natural. When you push it down, if that muscle's tight, it's going to actually pull me forward like that.
So face that way.
So this is a Sidelying ITB Test.
So way back there towards the back. So what you do, you have them bring their leg up. Oh, not that far. There you go. You would have them lift the leg up and bring it back. Okay. Stabilize here, like right above their ASIs to hold their pelvis in place. And then you see if this drops, she should be able to drop down and cross the other leg. Sorry, I'm in the way, but as you stabilize here, this should be able to drop down across her other leg. So that would be an indicator of normal flexibility. If it doesn't and her leg stops here, that's an indicator that the IT band is tight. You want to stabilize here to hold her hip in place because her leg can drop because her pelvis is moving. Okay, so when you hold this in place and it doesn't move, then you want to see if that can cross her body. So she's pretty flexible.
Doctor, you said something about like the leg rolling forward too, I think.
Well, to stretch this, to see if it's tight, you would want to do extension and adduction, right? So that's what you're doing. So you're testing the leg by bringing it back. I'm not sure what you meant.
Oh, like when you let go, like if it's tight, it'll kind of like roll.
Oh yeah, when you let go, it may rotate in slightly because it's trying to pull itself back this way. So it might natural. I mean, most of the time though, their toes are going to tilt towards the ground, so you'll get a little bit of that, as long as it doesn't do this motion, and it'll drop down here like where because it's so tight it actually gets pulled back forward.
Yeah. He was mentioning the bottom of the table. Do you actually push to see if it'll go, or do you like let it?
No, just in examining, you just stabilize here, okay, and then you just let this drop to see where it goes on its own. If I determine that it's tight, I can keep her there and push down to do a stretch.
And you see where he's grabbed the hip there? Sometimes stabilizing that pelvis, and then when you're stretching, applying resistance to it is going to give you that IT. A lot of us in here are not really tight there, and so when we do that little awkward test, it's like, I don't feel anything.
Because if I look at the top of her pelvis here and move her leg, this moves just a little bit. It'll go from here to slide down. All right, so you can't get a true test if she's tight or loose because her pelvis is moving. If I can hold that so it doesn't move,
right,
I can get a better indication of her IT band. And then same thing, if they're tight, you can keep them in that position while you have them there and do a stretch.
And just positive for, I mean, I said positive or negative, but if it's just tight,
if
how
it's
far
tight,
should it not go?
They should be able to at least cross the other leg. It may not go down past the table, but they should be able to at least cross the other leg. A pretty good indicator that it's tight would be that it'll just kind of drop to there and it won't go past the other leg.
Midline at least?
Yeah, so it should be able to go to at least midline.
Push that bottom leg forward a little bit.
You can,
yeah, you can bend the knee. Can't you bend the knee?
If you wanted to bend this one up to get it out of the way, you can do that. The bottom leg, it's not as important where it is, so it's kind of patient comfort. If they're obese and you feel like the other leg's getting in the way, bend it up, move it out of the way, do whatever you can to get it out of the way.
Because one thing with the ITB or IT band, it has to go into extension.
Yeah,
so hyper extension, if you will.
And adduction.
And so it can't just be in line with the body. It does have to come back a little bit in order for it to drop down.
So likewise, if you were going to give them a stretch that they could do on their own, same thing. You put it into extension and then cross, and then you would have them shift their weight, so you're stretching this one. So a lot of people will do that stretch and think it doesn't matter whether the foot's forward or backwards, but it does. You want it to go back the